Hey, this is Renew Education. Let's go through another case here that's pretty straightforward. I would say this is a good starter case for any of those doctors out there that are looking for an idea of where they should start. I like this case for a beginner case because of the access to the lower right side premolar area. And in particular, this patient on our treatment assessment is pretty much a green across the board. If we look at it, the bone density, the constriction, all these things, IA nerve, they're all pretty much green. So don't worry too much about that in this case. And so that's what I think of it as a starter. The other nice thing is that this patient has implants already. So you don't see any bridges here because the patient probably had experiences or thoughts about what is valuable to them. They don't want bridges. These obviously have a lot of goodwill to dentistry here. They have these older implants up there. They have root canals. They have crowns. Very few teeth don't have some sort of dentistry associated with them. Really nice guy, and obviously cares about his oral health, at least to fix it, but maybe needs a little more education on the oral hygiene instruction. So he had something fail here. I wasn't clear on. There's definitely a cracked root here. Must have been a bridge or something. I saw him later on after all this, but this is on day one that I'm seeing him. So let's look at this site here, and then we're going to look at this site and look at the bone quality, look at why this is such a good case, because when you're successful in this case, that goodwill that the patient's already kind of showing you that they have goodwill towards dentistry and that they're willing to put money into dentistry, they're not just going to let it go. When you're successful in these areas, I guarantee you he's coming back to deal with that fractured root canal or that decayed tooth that has a root canal or any of the other teeth that might have a problem in the future, which a lot of this is older dentistry, and after time it's all going to kind of go down. So let's look a little bit closer at that site here on number 29, and let's bring that CT over there. So here we go. That root is pretty shallow and the nerve goes down. You can go at least 13 some millimeters into this area. So you also have a very strong facial wall, right? So you don't have to worry too much about that. And you know exactly from your perspective, being on the right side, if you're right-handed, you're at an advantage, that you know where that actual bone height is. And you can pretty much predict that that bone height's going to stay. Just stay on the lingual side and you can take this tooth out, no problem. I don't do any kind of auxiliary grafts here. I don't do any membranes here. I do a straight extraction, and I probably bring the height of the implant probably just below about 1.5 millimeters or so, maybe from the lingual height of that bone out there, just to kind of cover the bases here. But that's a really nice one. Let's see. Let's put an implant in there. What size would we do? I always go to my go-to premolar stuff, and here I have the 4.2 by 10. We know we could go a little longer, so let's do the 11.5. And here's what that would actually look like. So if we went down, we're plenty fine. So let's delete those out. So here's the implant. You're hugging the lingual wall, maybe angle it, and now you've got this really nice situation where you know the bone isn't going to collapse into the area here. You have nice coverage. You're away from the nerve. If you're only using a pano, the problem is that the pano looks like this, and it looks like you're going right into the nerve, and you're really not. Now, do you have to go that far down? Maybe not, but I would look at it going that far, maybe this far. It's hard to say. So clinically, you got to kind of assess everything. The bone is not going to resorb that far down in a strong lingual wall position. So I think we're good there, and that would work out just fine. So now let's take a look up into this area up here. So we're in the upper left, we have the canine here, and we're missing a couple premolars. So the question is, do we do an immediate placement here because this is fractured out, this is a non-restorable area, or do we do 2 implants and then do a cantilever over into the canine area? It depends. So let's start off with tooth number 14 area and see how much bone we have. So if we're about there, let's look at that. So the bone quality is really good. I really like the bone quality here. And the sinus looks like it's fairly far up. So let's take a 5, maybe a 5 diameter by 10 just to see the sizing. Not that that's going to be it, but a little bigger for a premolar than I normally pick, but I just want to see what's going to happen here. So we have a lot of bone wall around this implant. We just touched through the floor of the sinus, which is not a problem, and I wouldn't be charging for any kind of graft or something like that. And the reason why I want to put it here and put a bigger one is, what if we did decide to do a 3-unit bridge on 2 implants? So now let's look at this site and see what we could do here. So would I do an immediate placement like on the bottom one? Well, this is a little trickier. This wouldn't be the starter one. If you want to make this a really simple starter one, then you graft it and let it sit. So let's take a look at what that would be. I would definitely go with a 13 now, because that root has such an angulation. And I would stick with the 4.2 or a 3.5. So let's do the 3.7, 13, and I'm going to put that in something like that, maybe. It's hard to say. Try to angle that more so you get a little bit further in. You want to stay on the lingual side if you can. So that's kind of how that would go. You probably will get some security with that. Maybe even go a little further in so you get a little bit more. That wouldn't hurt. But the facial wall looks pretty good for a canine, so I don't think that's going to collapse. The larger the implant, the less you have to worry about grafting that site too. So what if we took something else here? Let's see. I think a little larger diameter would be fine too. Let's get rid of this one. Your angulation for an immediate implant, that looks a little better to me. Maybe even do it that way. You can get into the lingual wall here pretty easily. So I do something like that. So if you now have less of a gap here, you don't have to worry about grafting. That'll heal forward. That bone is fairly thick, so that's pretty good. And what we're looking at is the angulation will still work for what we want to do. And how I design the surgery is I go from the lingual top of the bone to the center point of where I'm actually going to engage the bone and take a really sharp, 2 millimeter lancet burr or some sort of 2 millimeter twist drill that I can engage. And your drilling is going to be at an angle not like this into that area. You're gonna be angling it like this, so you can go in and then up is what you want to do here. So you go figure out the distance, get a perio probe, measure on your drill just how far down it looks to you, or if you somehow can figure out how to get that measurement. I use a technique with a perio probe with a drill together, so I can measure. If I hold the drill there, I know the feel, I know where I'm purchasing. You can even take a round burr, go along the lingual wall, the depth that you want, and then give it a little hit on that lingual wall. So now you know where you can actually engage, and you're only going to go in about 1 millimeter to 2 millimeters before you really start turning into the socket. You got to remember, you got to now bring it up and start carving that wall to get that implant in and get it safely so that you can get it more into a trajectory that you want later on down the road. So this is an interesting case to do, and now you're looking at a 3-unit bridge. Now this starts to make a little more sense if you're thinking about economizing or not putting as many implants in. You can do single crowns here as well. Patients like that as well. So here's where you would be now looking at this site. Sorry, the CT is cut off a little bit, but that bone is very generous, and putting an implant in there would be no problem at all. So this is a great, great case to kind of get your feet wet in a way, to get this done effectively, safely, and successfully. So when this patient has more problems down the road, they know that you're there for them. So let's see if we can just put that in, and we'll look at the panel view in just a second. And so here you go. So now you can have 3 crowns on here, all independent. They all are very strong. They all have good bone. You can do a media placement here. That's going to be trickier. That's an upper. It's more technical. Here, that's a very straightforward. That's a perfect first kind of implant, immediate implant placement kind of case. So this is the patient you want. And I'm grateful for patients that care so much and are interested and have good things going for them. So anyway, that's kind of it for this one. Stay tuned for more case studies. Take a look at those. We are on Facebook, we are on YouTube, and look for our live streams. All right, thanks.